Morning, dear colleagues. So I'm going to talk about our long-term experience with Glomus jugular tumors treatment with gamma knife radiosurgery. These tumors are called paragangliomas, and they are actually the clusters of neuroendocrine tissue which are dispersed in the body, and they are interconnected with the autonomic nervous system. There are two types, adrenal and extra-adrenal. Adrenal we know as the pheochromocytomas, and extra-adrenal are of two types, parasympathetic and sympathetic. The differentiation between these two is that the parasympathetic one, they don't secrete, while the other ones, they secrete. So the most common of parasympathetic are glomus jugular, glomus tympanicum, and glomus vagale. These are the various sites. The carotid body tumor, as we know, is present at the bifurcation of carotid artery. These are the skull base areas where we can find them, the jugular-tympanic one.
डॉक्टर साहब का माइक एडजस्ट कर दें जरा वॉल्यूम.
This is the histopathology presentation, which is called Zell-Bellin pattern, which we can see if we take biopsy from these tumors. On radiology, this is a salt and pepper picture. 80% of these are sporadic, but remaining are inherited as autosomal dominant. And there is a potential both for synchronous and metachronous tumors. And in recent years, the genetic analysis of the familial forms have attracted considerable interest. And we now know that the succinate dehydrogenase genes are the implicated ones, and they are the tumor suppressors, as mutation causes overexpression of hypoxia-inducible factor 1 alpha that results in proliferation of paraganglion tissue. This is the graphic presentation of the pathogenesis. Clinical features, incidence peaks at 45 to 60 years. There is female preponderance. They are benign, slow growing, but highly vascular and locally invasive. The symptoms are caused by invasion of adjacent lower cranial nerves, the mass effect, and high blood flow through the lesion causes pulsatile tinnitus, which is very cumbersome for the patient. The neuroendocrine effects are rarely seen. So the options we have: the surgery, conventional radiation, embolization, and radiosurgery. The problem with surgery is that this, as it was noticed in various studies, these tumors are noted to infiltrate between the cranial fascicles and the perineurium with reactive fibrosis. So even when the nerves are still functioning, and it renders the complete resection occasionally impossible without sacrificing these nerves. Moreover, the preoperative embolization does not reduce the risk of new postoperative cranial nerve deficit, and it itself carries a risk of permanent cranial nerve neuropathy because overlapping blood supply between these tumors and the cranial nerves. So we have treated since 2008 till 2020 at NCCI 3,525 patients, and at both models 4C and the ICON. 47 of the patients had glomus jugular tumors. A retrospective analysis were done. 26 were female, 21 male. The age ranges from 20 to 70 years, mean 42.8. 4 patients had undergone surgery before presenting to us, but none had previous radiotherapy or has undergone embolization. These is the various presenting symptoms: hearing, tinnitus, vertigo, hoarseness are the main features, presentable features. The FISH classification, we have mostly patients responding to D2 type. Initially, we started with the 4C machine, but in 2016, we are working on the ICON. Dosimetry, we usually give the mean margin dose as 13 gray. The range is 12 to 16 gray. Results: clinical re-examination and serial imaging every 6 months is done for the first year and then annually. The median time from the date of treatment to the most recent follow-up was 60 months. Range is 6 to 144 months. Neurological follow-up examination revealed improved clinical condition in 24 patients. It is 25%, and stable neural status in 7 patients, and recurrent growth in 1. Radiological results, MRI imaging is available for 24 patients. The median time from gamma knife to last follow-up was 60 months, range is 6 to 124. The tumor size has decreased in 15 patients, and the volume remained unchanged in 18 patients. in 8 patients. One of the tumors showed volumetric increase during the observation period, for which the repeat gamma knife radiosurgery was done. This is one case, 4.1 cc tumor, which we treated at 14 gray at 50% isodose, and in 14 months follow, you can see the decrease in the size. Another case, the same case with the coronal images and sagittal. Another case with larger tumor of 20 cc's, radiosurgery were done at 14 gray, and you can see the ongoing reduction in the tumor. The long-term follow-ups we have, like this one, this is the whole record which we keep as a patient is coming to us 6 monthly or yearly. This is the whole 10 years record, and in this case the tumor has decreased from 20 cc's to 5 cc's and is symptom-free and is being followed up till now. So gamma knife radiosurgery is a safe and effective treatment for primary treatment as well as the salvage therapy for residual recurrent cases, and it offers a low-risk benefit treatment option with stable long-term tumor control rate with minimal side effects. A treatment in early stage before tumors attain a large size potentially reduces the post-treatment complications. Just one news that I worked for the last 13 years at NCCI, and I have great gratitude for Professor Star Hashim to entrust me with this technology. But now the other options are available at Dow University Hospital that's having the same machine. These are the sources and machine being installed.
1 minute.
We will inshallah start work after the Eid. Thank you.